Yes, sir.
Good evening to one and all, and welcome to this edition of webinar of the Indian Academy of Otorhinolaryngology Head and Neck Surgery. And this is particularly an important webinar because it's very topical. It's a particular problem that we're all facing, and it's very, very daunting to each and every one of us. I think I have been practicing ENT for more than 40 years, and I can say in all honesty that in these 40 years, I have never been more frustrated than the last couple of months. You know, this surge of mucor cases coming in, and all of us being forced to deal with it, taking out bits and pieces of the human anatomy, as it were, and leaving patients with huge deficiencies and compromised quality of life. So it's a very, very serious problem, one which is taken the attention of each and every ENT is practicing individually or an institution anyway. And also came the realization that this is an issue which definitely needs multiple talents. It's an issue which has to be dealt with by many specialists from different specialties. And hence this particular webinar has a lot of meaning because we've had some of the best talents from other specialties also joining us. Now, the moderator needs very little introduction, I think. Sumit is known to each and every ENT surgeon in this country. Sumit is in Max Secret, Delhi, a very dynamic young man, who will not be easily forgotten by anybody who's come across him even once. So he's very, very talented, brilliant young surgeon. So, and he is the right person, I feel, because he has a lot of interest in this particular area, and he has shown a lot of leadership right from the very early days, and he led the task force of the Indian Academy in putting together recommendations in the very early days of the epidemic. Now, we have a very talented home group, Professor Neelam Ved, who again needs no introduction, from Pune, from KEM Hospital. And she did the previous webinar, moderated it, and it was a huge success. With, I think record numbers of people watching it. Dr. Manish Munjal, again, is a very academic, well-known name in, all over the country, from Delhi, and a person who has everyone's respect. And Dr. Rahul Modi, a very young, dynamic surgeon from Mumbai, again somebody who I really admire for his very good academic, clear concept. So it's a fantastic panel from the ENT side, and to give direction to us and to augment the information, we have a very eminent panel of Dr. Sunil Chowdhury, who is a plastic surgeon from Max Healthcare in Delhi. Dr. Aditya Murthy, who is a renowned oral and maxillofacial surgeon from Bangalore. And Dr. Sanjay Dhawan, a very well-known oculoplastic surgeon from Max Eye Care in Delhi. So I think without wasting any more time, I would wish this panel the very best, and the viewers to please note their questions so that they can, ask them at the end of the panel or direct it to Dr. Vijay, who will then pass it on to Dr. Sumit. So thank you all for taking time out on a Sunday evening. But I think, this is something which we're all looking forward to. So thank you once again for joining us, and all the best.
Thank you, sir. Thank you very much. Dr. Vijay, can I share my screen? Yes, please. Thank you very much, Dr. Mohan sir, for the kind introduction. It's been a pleasure, and thanks for the opportunity to me to moderate this session. And we all have gone through tough times, and this is part 2 of the mucormycosis webinar. And as you rightly said, that it is actually the need of the hour because all of us in the country have operated innumerable cases, but then we are now reached a stage where we need to look at part 2 of mucormycosis. And committee, Dr. Mohan Kameshwaran sir, who is the chairman, and Dr. Handa, who is the current president, and thank you, Dr. Vijay Krishnan, for this opportunity, who is the secretary. My worthy panelists, esteemed panelists, have already been introduced. I welcome you all. And before we start the case discussions in this webinar, we all have seen the wrath of mucormycosis in this second wave. Now, to give you an approximate idea about how much cases we have seen in this country, this is a rough idea from the Information Bureau. I have statistical data from different states, but total approximate mucor cases, what India has seen, which is the mucor capital in the world, is about 40,485. Out of these cases, around 31,344 have been rhinocerebral, and that's a huge number. Of these patients, since most of them have happened after this second wave, so of these, about 85%, that is 34,940 patients were COVID positive, and they developed this mucor infection in the after the COVID infection, after getting that. Now, a lot of talk has been about the diabetic status, that it has been predominantly in the diabetics, but the statistics says that it reflects about only 64%. I think there is some mismatch in the data provided by the government, but yes, this is what they say, that around 26,187 were found to be diabetic. And as per the data, 52%, that is 21,523, were on steroids. So maybe the last two statistics, I think they are a little underreported, but this is what information we have. Now, talking about why such an outbreak, we saw few cases even after the first wave, but it was never like what we saw in the second wave. And this is what I was going through the literature and found out an article, in fact, written by Dr. Aditya Murthy, who is our panelist, who tried to find out an association. And yes, uncontrolled diabetes, unscrupulous use of corticosteroids played a very important role. But I think the virulence of SARS-CoV-2 virus in the second wave was equally responsible for causing this infection. Now, as ENT surgeons, like Dr. Mohan sir rightly said that, we have never been so pushed hard to a corner where we are actually not being able to provide that treatment. And all of us are working in good corporate hospitals, good medical colleges, but then this time the challenge in treating this mucormycosis has been tremendous and actually very, very disturbing to all of us. And there are reasons. So probably the country was not prepared to take up a second pandemic after the COVID pandemic, the second wave, an outburst of mucormycosis. We have heard, drug shortage across the country because there were not too many manufacturers. People were not aware about an infection which occurs in in transplant recipients in hematopoietic stem cell transplant. Suddenly this COVID infection going and having patients having mucormycosis. So we were, or I would say any country which faced a shortage of drug across it. And the rapid progression of the disease, we hardly could get time in understanding the disease. The patients came late, and that is why the morbidity and the mortality was very high. And finally, I would say that we were already so much overloaded by tackling this COVID second wave with oxygen shortage that we all were actually overburdened by this sudden pandemic of mucor, and which made it more challenging. So let's talk today about the recurrence, the resurgence, and the rehabilitation, because this is very important, because we need to have a part 2 of this mucormycosis infection where the patients have got their surgeries done. They are coming back with recurrence. They are coming back with morbidities, and we will focus on case discussions based on this. So I would start my first case. Now, this is a 35-year-old male, COVID recovered, non-diabetic. He had hospital stay for about 9 days, and he was on oxygen intermittently. He was given steroids, Medrol and prednisolone. Now, the blood markers, he had lymphopenia. but the glycosylated levels were normal. The D dimers were also normal, but the CRP and interleukin 6 was high. Now, the patient presented to me after he had been worked up in 1 or 2 hospitals. And the patient came to me then where he had some swellings in the gum area. And this happened about close to 2.5 to 3 weeks when he had an infection, COVID infection. And apart from this, he started complaining of left nasal blockage. The vision was normal and there was no epistaxis or the nasal discharge. The patient underwent a biopsy in a hospital, but the results were inconclusive. Now we got the radiology, the CT scan and the MR scans, which were already done. Now the CT showed heterogeneous enhancement in the left maxillary sinus, whereas the MR on T1 and T2 weighted images are displayed here, where it shows brightly enhancing lesion occupying the left maxillary sinus. Now, if we see the course of disease of this patient, COVID recovered, nasal blockage and jaw pain, upper jaw pain and swelling in the gums area. Now, CT scan and MRI was suggestive of invasive fungal infection. So the surgeon took a biopsy from the nose, and which was inconclusive. The nasal KOH swab test was also negative. So we planned the patient for a left functional endoscopic sinus surgery. Because the disease involved the anterolateral part of the bone of the maxilla, we decided to go for a Denker's approach. But to my surprise, when we got the histopathology report and on table KOH, we sent all the specimens. It showed mild sinusitis, negative for granuloma, fungal profile, and neoplasia. And it shows just dense, acute on chronic inflammation, leukocytic debris. So the patient was happy. We had started the patient on admission on liposomal amphotericin B, but after getting the histopathology report, we stopped it because there was no clear-cut evidence to give this patient amphotericin B. Now, this is the post-op MRI scan. Apart from the secretions in the ethmoidal area, the cavity was quite clear. The patient was very well settled. We were doing regular nasal endoscopy, suctioning, cleaning in the OPD every week, and the patient went home back. Now, the problem happened when the patient was fine for a month. He had no symptoms. Everything seemed to settle down. But suddenly, after a month, he again came back to me with a complaint of swelling in the jaw, in the gums, and similarly what he had on the first day of the presentation to me in the hospital. So we consulted our maxillofacial surgeon who advised a CBCT scan. And there in the CBCT scan, he suspected some deep fungal infection, suspected mucor or invasive because there was some cortical bone erosions. So finally, the patient got an allylectomy done, but the biopsy report again came absolutely negative. Again, acute on chronic inflammation. There was no sign of any mucor. In fact, now in the post-op, the patient has a small perforation going from the alveolus and it is opening into the nasal cavity when I clear the maxillary area for suction cleaning. Now, the case is open to discussion. I would invite Dr. Neelam Vaid to take a call on this. How do you manage such cases? I'm sure in your practice, you must have seen such cases. What do you tell to the family? Because the family is very frustrated. What it is not a bacterial infection. It is not a viral infection. It happened post-COVID, completely mimicked mucor. So what your take on this?
Thanks, Sumit, for the invite to be a part of this panel, firstly. We've had a couple of cases very similar to this, where we've sent repeated biopsies from the mucosa and they've all turned up negative. But when we've done the CT, as you've done a CBCT, we've seen that there's been cortical bone erosion. In our patients, it's also been the same. It's been the alveolus. We've also seen a couple of them involving the zygoma. I think a lot of these patients have two issues. One is they do have an associated osteomyelitis of the bone, and this is something that we are picking up later. So initially you're treating them as mucormycosis, like you rightfully said, you send them home and then they come back with these abscesses. In our case, all the mucosal specimens came negative, but when we sent the bone piece, they were able to grow mucor from that. So we really got after a pathology department that, look, clinically, we definitely think this is mucor. Can you really look for it? And finally, I think in one of the specimens, after they did an extensive decalcification of the bone of the zygoma, they were able to grow mucor. Yes, it's a challenge talking to the family, but what we do to tell them is, look, clinically, I suspect this is mucor, given the entire history. At the end of the day, one has to realize that the histopathologist actually reviews the specimen that we are sending. And sometimes, however much we may feel, we may not have picked up exactly that tissue where there was mucor. There may be an issue in the processing in the lab, the way it was transported from the OT to the lab. There are all these things where things could have gone wrong. So in my personal opinion, I would still treat this case as mucor. I would speak to the family, tell them, look, as far as I'm concerned, this is a patient that needs amphotericin. And irrespective of the fact that I'm getting a negative report, I am going to give you amphotericin. At the same time, the culture of the bone would also be sent. Do I need to add a secondary antimicrobial? Would depend on that. But this is not a rare phenomenon, I would say. Instead, now with following up our patients, we are seeing a lot of them coming back. You're putting the nasal endoscope, everything inside looks healthy, but suddenly they will develop these pustules in the gingiva area. And sure enough, when you do a CBCT, you see that cortical erosion coming up and you have to do a second stage alveolectomy. So I think this is something that we are seeing long-term follow-up.
So you want to say that in spite of all specimens, all reports negative, now the patient has been discharged in the last 2 weeks. The patient is again coming for suction cleaning. He is absolutely fine. There is no sign of I can see any black crusting or anything. You would still like to give this patient amphotericin?
If your patient is discharged and you want to be a little more conservative, then at least put him on Postcanazole. But I would definitely cover him with an antifungal. I'm not comfortable. I have too much of a history. I have a COVID. I have this developing. I would rather give him Postcanazole. So if your patient is not an indoor patient, then definitely at least Postcanazole would be given.
Dr. Manish, any points you would like to differ? Would you also like to put this patient on amphotericin if he's admitted or on posaconazole?
Well, first of all, the patient, the kind you have, we also had quite a few of these kind of things. The only good thing about these things, in spite of the frustration, is that these are possibly the best managed and the best prognosis patients if it's an isolated alveolar involvement. Yeah. My patients have been the happiest, at least in terms of disease recurrence after definitive surgery. Well, I was lucky that 4 to 5 patients we did, I'll not call it inferior alveolectomy. It is a partial maxillectomy that we do. I like to go up till the sinuses into the maxillary sinus, preserve the palatal flap below, and then later on suture it with the gingivobuccal sulcus mucosa.
That was done. No.
What I'm saying is, having said that and getting the biopsies, even if it is negative, I would like to put this person, almost everybody I put on 3 gram, which is my lower limit of in one segment involvement, like I do in mucor, that if there's a one site involvement, I give 3 gram minimum. So 3 gram, all of them have received and they have all done well without recurrences. Yeah. Further recurrences.
Dr. Rahul, are you there?
Yes, Dr.
Would you like to get any other diagnostic test? Any role of this PCR test for mucor, which was introduced quite late? No?
Yeah, so excellent point made by Dr. Neelam and Dr. Manish. I would like to differ here. I've had 2 patients where we had necrotizing infection actually. And the picture looked clinically, I mean, these are all actually bad COVID patients, received everything, steroids, tocilizumab, and there was a lot of scare. In fact, the patient's daughter was a dentist. So there was a lot of talk about mucor, and we took up the patient for surgery. We didn't find anything in the histopathology. The culture grew streptococcus. We thought we will withhold amphotericin till the final pathology came in. The patient started responding to antibiotics very well. But what happened is when we stopped the antibiotic after 2 weeks, the swelling started coming back. And we restarted the antibiotic. This time we took the help of CRP to guide us. And we gave a total of 1.5 months of antibiotics. So this guy, the way I look at these patients, they are severely immunocompromised patients where even simple bacterial infections may place hold. So till I get a tissue diagnosis, and if I feel, my approach would be if I get something on culture, then I will treat it as per like a severe bacterial infection. If it is not responding, then perhaps I can think about adding either a posaconazole. My personal preference is for isavu, because we have seen great response with the isavuconazole, and the bioavailability and other issues are not there, which are there with the
We'll come to that. So we'll come to that. So you will also put this patient on oral posaconazole if you're not getting
not at first. Not at first. I'll try to culture something.
No, nothing is coming out. Rahul, nothing conclusive has come out in last 2 surgeries. Nothing has come out, and the patient is stable now. He is not showing any infection. He is not showing any blackish nasal discharge or any crusting or any mucor signs after the alveolectomy. It's about 2 weeks. So will you put the patient on posaconazole?
No, I would not. I would follow up the patient, keep him close to my chest, do a regular imaging and endoscopy, try to grow a culture if I get some dead tissue, some discharge coming out of there, and try to identify the organism. And then perhaps if there is clinical progression, then perhaps I can think about starting the patient on posaconazole if I'm not able to culture anything, but not just as a prophylaxis.
Okay. So, Dr. Neelam, we have put this patient on topical steroid spray for the inflammation, for the reactionary mucosal hypertrophy, and the patient was on antibiotics. So the patient is right now quite settled, and we have not received anything. So we are following up this patient every week and looking at his symptoms and the progression as well. Yes, Dr. Dhawan, you would like to make it a point?
I just have a small comment to make, and that is that when you take the specimen for biopsy or for culture for anything, it has to be from the healthy tissue surrounding the dead material. Because if you take it from the dead material, you will not get anything. In the dead necrotic tissue, it is not possible to get the fungus or any organism. It is the healthy tissue surrounding it where the likelihood of finding the fungus or any other organism is high. The reason being it's causing infarction. The infarcted dead tissue will not grow any organism at all. So that's my point. And usually we need to take specimen from multiple sites and not just one site.
So that was done, and but in spite of that, we couldn't get anything follow-up. Now, the patient after alveolectomy developed a small perforation in the alveolar area where the bone was removed, and it was just a mucosa which is lining the maxillary floor. Dr. Aditya, are you there?
Oh, yes, I'm here.
So there is a small perforation, and the picture I showed in the endoscopy, we can see the sutures. Now the sutures have been removed. Would you like to address this right now, or you would like this to heal and maybe see it quite later on?
Do I have to answer only this question, or can I put in an opinion of my own?
So maybe, your opinion on continuing oral posaconazole versus
No. I need to go a step backward here. Osteomyelitis has existed before COVID.
Yes.
Both bacterial and fungal.
Yes.
Invasive fungal infections have existed beforehand. This is a vilified pitch we are batting on. What I would like to begin with my little experience as a maxillofacial surgeon is that what you are seeing is late avascular necrosis. The reason why I wanted to say something here is that don't be very surprised if this chap's premaxilla falls off. Just a word of advice, because it's your patient. Don't be very surprised and be ready to talk to him about it. Point number 2, what we've noticed, but we have expected this. We are not surprised. This has happened before last year, and it will happen again. What we notice is that initially, there is going to be a fair bit of avascular necrosis with secondary bacterial infection. This is to be separated from a diagnosis of osteomyelitis, which can happen de novo. Fungal osteomyelitis also, like Dr. Rahul Modi pointed out, if it could also be bacterial osteomyelitis, and it should be treated as such. But Dr. Neelam Vaid was very astute in what she said. We are in Texas right now. If you hear hoofbeats, think horses, not zebras. We are going to end up with a kind of a slight overdiagnosis of mucor, but underdiagnosing mucor is exceptionally dangerous. So look very hard repeatedly for mucormycosis, and so long as we keep an eye on the liver, posaconazole is a reasonably docile drug. There is very little lost in keeping the patient on posaconazole. Your case looks very much like mucor. Point number 2, as far as this late presentation is concerned, this happens purely because the palate will look normal. the palate gets its blood supply. Anybody who does any amount of cleft will know that, or orthognathic surgery will know that we can clip off the descending palatine without losing the palatal tissue, either bony or soft. So most of the blood supply comes from the branches of the ascending palatine artery and the collaterals thereon. So even if the descending palatine coming down from the IMAX is thrombosed because of mucor, it's going to take a fair bit of time for the soft tissue to go, or it may not go at all. However, with the frank invasion of bone and probably the infraorbital nerve and the infraorbital artery coming down to supply the anterior maxilla, the bone is going to go eventually. So when this happens after some time, and hence you are going to see late avascular necrosis with osteomyelitis.
So this patient should be followed up for a frequent endoscopy. Any role of follow-up doing a regular MRI scans for this patient?
Yes, we have a particular protocol we've come to. I'm sure you have developed your own protocol. There is no right or wrong. Kindly follow up with MRI. But I wouldn't stop at a CBCT. As a dentally trained person, I should have a soft corner for CBCT. I don't. I do a CT-PNS because we have an integral team here, and even the ENT people get a lot more information than the CBCT would for the rest of the sinuses. You will also probably pick up a little bit of osteomyelitis of the other areas of the facial skeleton, including the base of skull. This or just some amount of sclerotic osteomyelitis.
So we should watch for any progressive osteomyelitis in this patient.
Yes, and that necessarily is not nasty mucor.
Yeah.
These patients, as far as outcome, as far as mortality is concerned, may not do very badly at all, but they will lose some more tissue.
Yeah. So I, based on this, I also searched the literature regarding maxillary osteomyelitis. There are two papers, one published from UK, one is from Indian study. Maxillary osteomyelitis is a little rare as compared to mandible osteomyelitis, of course, but it does happen. And point well taken that follow-up for osteomyelitis, or maybe right now treat this as mucor, because posaconazole is not a very harmful drug, and maybe the patient can be put on for about 1 to 2 months. He's a young boy and with a strong liver, non-alcoholic, so maybe we should go ahead with that. Thank you for your feedback on this. Now my case number 2 is a 60-year-old male, a COVID recovered. He was under home isolation and steroids were taken at home. This was the time when
Sumit,
yes.
We haven't answered the previous question, the last question, whether perforation in the palate.
Yeah, Dr. Aditya.
Oh, sorry.
You just missed about the.
Yes.
So we'll go back. Don't worry.
Yeah. What was that particular question about the perforation in the palate?
Would you like to address the perforation, a small perforation in the alveolar area, after the alveolectomy, or you would like to heal it and then address it at
in a hurry? No, for the reasons I've just elaborated on. I'm anticipating that 2 more teeth or that alveolar segment in the premaxilla will go or might go. So let's not hurry with the repair. And one more thing I've noticed is generally post oral communications, the first week or 10 days, we don't repair them because the tissue is friable at the edges. And in mucor, more so. And I'm still suspecting, like Dr. Ved said, that this could be mucor. And we probably would leave it for 3 weeks. 3 to 4 weeks later, if the bone's holding on, looks healthy, the next surveillance scan, by all means, we go ahead. In the meantime, you can get your prosthodontist pop in a very nice obturator. These things they work like magic. You can take out the Ryle's tube. He won't leak into the nose. He can have near normal food as long as it's not hard. And it will not lead to any kind of impact on his quality of life.
So we will talk about use of obturator, a temporary or a permanent obturator in the subsequent cases.
Sure.
Thank you. Thank you. So going forward to case number 2, this was an old gentleman, around 60-year-old male, again recovered from COVID. He was under home isolation, and it was a time when they were not getting bed in the hospital. So he took steroids at home, not a known diabetic to him. But when he was admitted, his markers, the interleukin was quite high, again had lymphopenia, D-dimer, ferritin levels were very high, and his glycosylated hemoglobin was around 8. And this was what we saw him. And he complained of blackening over the nose and the cheek, decreased vision. When he was admitted, PL was already negative. He had frequent headaches and nasal blockage with nasal discharge. We got the MRI scans done, and which shows infiltration going into the orbit, and there was a enhancement in that area. And based on that, there was extensive pus. The entire septum, the turbinates, everything was completely destroyed inside. There was a lot of pus. We drained it, we debrided. You can see large, big sinuses on the face, and the mucosa was also debrided to save the patient. And this is the picture after about few days, and orbital excision was also done. Now the patient is under follow-up. Surprisingly, with this extensive disease, the patient received about 3.5 grams of amphotericin B, did fantastically well. He was one of the early patients when the drug was not available, and but he received the drug and he was discharged, and he's under constant follow-up, and there has been no recurrence in the disease. So I sometimes wonder that we are seeing very different results in different patients. And now the main thing is, post-op follow-up, planning and reconstruction. So can I have Dr. Sunil Chaudhary? Sir,
thanks.
Are you there?
Thanks, Sumit.
Yeah. So, sir, I still remember while we were debriding this patient, your team came in and we asked them for timeline for the reconstruction, that this is the stage of the patient. So how do you, timeline these reconstructions? Number one, I would like you to take that. Or can reconstruction be undertaken simultaneously with debridement in such cases of mucor?
So we never do simultaneous reconstructions in these cases, because one has to not only be very careful that the mucor is completely gone, and that's the reason why repeated biopsies from the healthy tissues, as Dr. Dhawan was alluding to as well, should be done. The other thing is the patient is just recovering from a very bad disease. And a lot of these patients may require very complex microvascular reconstruction, so they may not be up to it as well, because post-COVID, as you know, still the morbidity and the mortality, with surgical procedures, especially the long ones, can be quite high. All the, the eye is already gone, so obviously there is not much that you can do to the orbit as such, apart from just filling the volume. The maxilla and all, in case if there is actually a temporary, thing to be done, as Dr. Murthy was alluding to, you can actually use obturators, as a temporary means. I would normally wait a fair 1 to 2 months before we actually do some major reconstruction in these patients, because such a patient, he looks like an old patient as well. So they would require fairly extensive, and many times they might require a combination of flaps as well. This particular patient may require a microvascular pre-flap, may also require a forehead flap for the nose. So it could be a complex, combination of flaps as well.
So how do you ensure, of course, the patient is under follow-up, MRI scans are done. The wound looks absolutely healed now. It is granulating well. There is no pus. So any special investigations do you get before planning? Because I think something which is on your mind is, if the flap also fails, then it will be a big disaster in these patients.
Absolutely. So I don't do a particular imaging for this, because already these patients have already had lots of imaging done. Okay. But what I would love to do is love to do the final debridement myself, because the way I would look at the tissues would be slightly different from maybe the time when the debridements were being done, just to clear up the mucor. So as it was being alluded to by Dr. Murthy as well, and I completely agree that a lot of the necrosis of the bone is avascular necrosis, and that's the reason why a long time after the infection is off, you have these maxillas totally fall off. When we open these up, you can literally pick out the skeleton and put it on the table.
Like a sequestrum.
There is no disease. It's like a sequestrum. It's actually, in the past, even before COVID, we, saw a few mucor cases, and we always, whenever we opened up, it was such an easy debridement, because you could literally pick up the bone pieces, and basically the wound was absolutely clean. We just took some biopsies, and the second stage was just do reconstruction. So as a precautionary step, I would always do one more debridement before I actually do a major. Okay. And one cautionary tale here: when you look at the nasal loss of the ala, one would never attempt and do a nasolabial flap here, because the whole reason why this nasal ala is gone is because the blood supply in that area is gone as well. So if you would like to, if you would try and turn over a flap from the nasolabial area, it would definitely fail. So the way to do this would be a forehead flap.
A forehead flap or a microvascular flap, you would be more happy.
Microvascular flap for the rest of it, but nose you would probably require a forehead, or you could do a double pedal microvascular flap in some of the cases. But you would use a forehead flap on the opposite side pedicle so that you don't have a problem, because you can see the orbital side is also gone.
How worried you will be with the failure rates, seeing that it was a case of mucor and probably waiting time, you said 1 to 2 months, because the patient is on oral posaconazole for 2 months after he has finished his amphotericin. So would you like to wait for some time after the posaconazole treatment has also stopped for the disease to come back, or you would be comfortable doing after 2 months?
No, personally, I think there is no hurry. I think you can easily wait till the whole treatment is off. I would normally take up these patients once the medical treatment is completely done. I've had patients transferred from other institutes in the past, and the treatment is all over, and we just take over and start afresh. There is no mucor when you're actually doing these patients. They are reasonably, well medically as well, because you need to build them up. So I don't think a maxillary defect or an exenteration defect like that has any real emergency on the whole. You can easily maintain these wounds well with dressings or washings, and I think you can plan it.
Sir, how about, doing the reconstruction? So probably 2 flaps for this patient. And how about eye reconstruction? You said, Dr. Dhawan, would you like to collaborate with Dr. Sunil Chaudhary in such a case, and you would do it simultaneously, or you let him do the microvascular and the local flaps and then you plan for the eye reconstruction?
So first of all, the timing it has to be like once you're absolutely sure that the whole disease is completely gone and cured and person's general condition is improved and local tissue has become healthy, which may, and granulation tissue has formed all over the area. So because it's not infection alone, it is a vascular disease that we're dealing with now. So I would say 2 to 3 months time after the, the disease. And then depending on how extensive is the damage, we can do, say, the things together. But here, like in this case, since the ALA is involved, so forehead flap, which could have been used for orbit, will have to be used for the nasal area now. And for the orbit, we may have to use the temporal muscle flap, but that can be done together.
It can be done together. Yes, Dr. Neelam, you want to make some point?
Just needed to know, you said you gave him an amphotericin of 3.5 grams. Was that because of a limitation of the dose?
Yes.
Or?
Yes.
Okay.
So the patient was admitted, he received 3.5 grams, and after that there was no supply. And it just happened when we had the initial 5-6 days, and then it was a rampant increase, and then the drug just went off from the market. So then he was discharged. So for all the patients, we did a follow-up MRI. The disease is quite stable. The patient is doing very well. This is why we are also a little surprised. Different patients, different age groups have responded very different to the drug availability. And some of them have done quite well. And the disease is non-progressing in him. In fact, his all tissue has granulated. He's seeing a plastic surgeon. And he's planned for reconstruction in about a month's time from now.
Just one more question, Sumit. I mean, we're all talking about flaps. I just need to know, do we also think about prosthetics here, or we're discussing that separately?
No, we are talking about prosthetics as well. So Aditya Murthy will be talking about prosthetics. We'll talk about that pertinent to the cases. Yes, Dr. Manish? Yes, sir. Dr. Manish?
Yeah, exactly. I was, what Dr. Neelam just said, we have such beautiful orbital prostheses these days for the eye, and those would be amazing. But if you are going to talk about it.
Yeah, so we will talk about it. So there is a video I came across, on the internet, and I thought it is worth showing. And are we also planning something like this, This time.
Сон, помоги. Подержи. Протез подержи. Протез тоже снимите, пожалуйста. Давайте сюда. Отдайте. Открываем рот. Anjati. Oh, he was this. Very. I think Anjati.
This showed me a lot of promise, and I was thrilled to watch this video, and I actually thought of including this. and this is fantastic. It looks very well rehabilitated, and I would like Dr. Sunil Chaudhary and Aditya Murthy to comment on this. That where are we actually?
Well, let Dr. Sunil Chaudhary go first.
Yes, Dr. Chaudhary, please, your comments.
So I think this is quite a good job, and I think from cosmetic point of view as well, even with the flaps, we couldn't have achieved that because most of the flaps would be volume fillers. Having said that, I think such a large prosthesis probably would have problems in the long term, because I think the one process is dependent on the other, as you can see here.
Yes.
And I think it's bound to have problems in the long term.
It's a composite.
It's bound to have leakage. It's bound to have leakage in the long term. It's bound to create problems in the long term as well. As a plastic surgeon, I would say that a lot of this, because this is a very large volume area, I would probably fill it up with a flap. You could always do prosthesis from the top because there is bony scaffolding all around. So you could do a cosmetic prosthesis which is much smaller, just like the orbit in the eye you got here. You could easily do that because rest of the palate and the inside defect one could easily fill up with a free flap. So I would rate that as a combination. A hybrid model is a better model.
Okay, right. Dr. Aditya?
Yes and no. I agree with Dr. Chaudhary largely here. Contrary to the popular belief, maxillofacial surgeons do agree with plastic surgeons. Yes. If anything was taught to me by my stint in the UK with the prosthetists, they are brilliant. Yes, this can be done here. I will very quickly elucidate a few problems with this one. First, it's terribly expensive. You've seen 4 different customized implants here. We certainly have the technical capabilities to do it. The material is terribly expensive. The implants have to be 3D printed. The implants have to be custom made, and the implants have to be placed with appropriate 3D planning. You cannot eyeball these cases. Point number 2, actually it looks very good, but you have paused it in a very appropriate place. You can see that there is daylight between skin and the prosthesis.
Yeah.
This is actually not an ideal prosthesis. This gentleman has had a less than ideal prosthesis because this has the prosthesis, the silicone needs to be knife edged over the skin and it should be gently peeled off. That is how these ideal prostheses sit. This is going to lead to a lot of crusting. This is going to lead to a huge amount of maintenance. This is not something that's going to be easy to maintain, not for the average patient, not just Indian, trust me, not even to the rich, well-maintained, well-to-do Caucasian white patient in the so-called developed countries with significant social backup. So these are extremely difficult to maintain. However, when we speak of reconstruction, the place where I disagree a little bit with Dr. Chaudhary is that my prosthodontists have always had a problem with me because we think of reconstruction, shutting off the mouth from the nose and the sinuses. But the ultimate aim here is going to be rehabilitation. Rehabilitation is finally functional rehabilitation with teeth. If I have an opportunity, I will speak later. But a lot of my patients have been aghast about the fact that I'll remove all of their teeth with the maxilla than the fact that we are going to chop off their eye. So rehabilitation is paramount, and we'll have to balance a little bit of volume reconstruction with rehabilitation. So the palate, probably we cannot just fill it up with volume. We'll just have to put a flap in to fill up most of it with volume, but with enough space for prosthetic rehabilitation.
Right. So a combination of both of them would work much better than either of them. Yes, Dr. Munjal, you want?
Make a small comment.
Yes, sir, please.
Yeah, I actually totally agree with him as well. So contrary to belief, the plastic surgeons agree with maxillofacial. I think there was no disagreement as far as you're concerned. Just that he clarified a point which I think even when I put bone flaps, one of the mistakes a lot of people do with bone flaps is they actually keep it almost level with the palate, which is a mistake. You keep the bone flap a little higher up so that there is enough space for a prosthesis to actually go on. So when I actually put a fibula flap as well, I would actually position it much higher. So there's actually a gap between the flap and the real palate, shelf. And that seems to work much better, because if you just put a flap which is just, Yeah. So I think the point very well taken, and I think I completely agree.
Yes, Dr. Manish. You want to say something?
No, I had made the point earlier. Nothing new.
Okay.
Yeah.
So I think we are glad to have the plastic and the maxillofacial, syncing with each other on this panel. That's a great. Now, coming to the point, sir, which I asked you, that can single-stage microvascular reconstruction for facial mucormycosis safe? So it's an interesting article I found out, and it's from Indian Journal of Plastic Surgery, where they had a series for about 7 patients, and 5 of them actually survived quite well. It's a great article, you must see, and it showed all the pictures where, except 2 patients who actually died in the post-operative, and that was because of the aggressive mucor on 27th and the 6th day. Rest 5 of them survived quite well on the day when reconstruction was done along with the debridement. So that's why I had put that question, that is it, do we recommend, is it practice? But this paper I found in the literature.
I'm not sure why they've done this.
Yeah.
Because what is the hurry in doing this reconstruction? I mean, this is not really impacting anything as far as the patient's concerned. If you wait for a month, 2 patients have died, that means that the disease was still active.
Yes.
And you're actually doing major reconstructions here. You're jeopardizing, maybe the flap itself is actually camouflaging and covering up, the thing. You can't actually clean up the areas as well. So I'm not sure why they're doing
this. And
if you read, I won't justify this at all.
If you read, they did free flap, soft tissue free flap reconstructions, and everything was done. So just wanted to bring
just
up.
Because you can do it, you shouldn't do it always.
Okay.
So I'm not sure why they
Point well taken.
I'm actually quite surprised that they had the temerity to publish it after doing it. Very honestly.
I think it's almost unethical what they've done.
So point taken that all these patients need to be followed up, and we need to wait till the disease subsides, the medical treatment is over, and then we need to carefully plan with the plastic and the oral and maxillofacial together, right? Yes, Dr. Dhawan.
Yeah, Sumit, in this one, they talked about the mortality or the survival thing. They've not talked about what was the outcome of the reconstruction, whether there was the disease came back or not. No, so that has not been mentioned. No.
So the article says, if you read the full article, it says that 2 of them died, but rest 5 of them survived quite well. It was not.
What happened to the reconstruction part? Did it do as well or not? No.
They did well. The article says that 2 patients had problem, but the rest 5 did fairly well in terms of there was no necrosis, there was no failure of the reconstruction site and the flaps. So it's quite a surprising article, and that's why I thought, let me just put it here and ask.
Come on, Sumit. 2 out of 8 people have died. What kind of outcome are we talking about?
Yeah.
I just don't know what this article is worth, actually.
Great.
And this article can be only to condemn it, very honestly.
One little question, if I can ask Dr. Sunil and Dr. Aditya, because I have 2 patients. I just wanted to know, in case 1, for orbit, our oculoplastic surgeon, they are using a lot of superior and lower palpebral flaps, and they are doing primary closure of orbital defects, and it is kind of doing well, not bad. We don't have these now, the socket defects that we have in all cases. Of course, if the palpebra is involved, then we have it. This is question number 1. How much do you support that? And number 2, for the palate, because as we all discussed, the flap does not necrose, and it's pretty good quality mucoperiosteum in that. And primary closure with the buccogingival sulcus really functionalizes them well. In fact, in one of the cases, sir, he requested, and when I took off I did an inferior maxillectomy plan, and when I opened up through a sublabial approach, I could remove the premaxilla and the inferior, maxilla separate from the teeth, teeth sockets. And if I lifted it off and tried to, I pulled down the teeth so that I could close. Then I realized that I could just close it above that with the sublabial incision itself. And it's been almost 2 weeks. The teeth haven't fallen. They're swinging, but they have not fallen down. So he's happy. He's saying, you have saved my teeth, but I don't know what's happening. So these are the 2 things which I thought one of you could answer. Yeah.
Quick comment, Dr. Aditya. We are.
Yes, I know. Okay, very quickly. Yeah, I won't leave the teeth back. point number 2, yes, if there's no actual perforation, and even if there's a perforation, we just lift the palatal tissue out and we suture it back. A very quick tip, if you, instead of a sublabial incision, if you would just go around the neck of the teeth, it is called a clavicular incision in the dental parlance. Even retain the papilla in between the teeth if it's not infected. Papilla is keratinized, that's keratinized tissue, very good for closure. It holds sutures very well. That's something that's perfectly fine to do. The point number 2 was, you were speaking about using the lids. Basically what they are doing is called a lid sparing orbital exentration, as opposed to old-fashioned conventional orbital exentration where the lid was removed. That is perfectly acceptable. Sometimes the wound breaks down, but that's fine. And if there is enough left over, the bulk can be filled up with a temporalis flap, which I do. That's about it from my side. I'll see what Dr. Chaudhary has in his mind.
Yeah, no, I agree with that.
Great. So we move to case number 3. That's a very interesting young male, 43-year-old male, COVID recovered, non-diabetic. He was admitted for COVID in hospital for 7 days, took steroids, and had high D-dimers, interleukin 6, but had lymphopenia. So, he came to the OPD with, he felt like heaviness in the left cheek and below the orbit and numbness in the gums area, and with normal vision and no headache. We did the endoscopy and we realized that there was a pus coming out from the maxillary sinus area, from the maxillary ostium area. There was a bluish discoloration of the turbinate, some erosion, and we took the swab. And in 30 minutes, we got the report. And it showed mucormycosis. And we got the CT scan done. And we immediately took that patient up for surgery, cleared the disease. The patient was kept on IV amphotericin B for 10 days, liposomal. The patient was discharged, endoscopy done. This is again the time when the drug was limited in short availability. For 10 days, he received it, but after that, there was no government supply. He was not getting any drug. We put him on oral posaconazole. He's still on oral posaconazole, regular ENT follow-up. Now, after 1 month again, there is pain in the left jaw. There is numbness, which was his first symptom. It is persisting in the upper lip and the cheek area. There is fullness in the left cheek. I did the endoscopy. So there is inflammatory polyp area, polyp formation in the left maxillary sinus because we debrided that part. Again, we got a CBCT done, which showed about some cortical breach erosion at the root 26th. And we got this MRI done. So you can see just ballooning of the polyps. Otherwise, there is no mucor right now. What to do? Rahul, my point to you is patient is not keen to get another surgery done. He is not keen to visit a maxillofacial surgeon. He says, I will wait and watch. He says, I am taking oral posaconazole. He will continue it for 2 months. How do you counsel such a patient? What is your right treatment in this? Whether alveolectomy should be done based on CBCT and his numbness. There is no swelling. There is no swelling in the gums area. But based on the CBCT report, what would you advise this patient?
I would go slow.
You are muted. Rahul, please unmute yourself.
Are you able to hear me now?
Rahul, I can't hear you. Rahul, I can't hear you. Yeah, that's fine. That's fine.
Okay. Great. So, we are seeing this challenge, and the challenge comes in to know, to find out, one, if the disease is progressing on medications or if it is a stable inflammatory response.
It's not progressing. Disease is not progressing, but for his numbness and a little pain, not much pain, we got the CBCT, and CBCT shows focal erosions at 1 or 2 places.
Sure. So I would be slow in these patients. The numbness may take a long time to recover and may not recover completely also. That is a counseling that I do even prior to taking up for the first surgery. And if the nerve is involved, the nerve and the pain also may be part of the recovery process. It may be part of the paresthesias that the patient may, experience as part of the recovery process. So if there are no inflammatory, if there are no new imaging findings, if there is no clinical progression, patient is otherwise fine, I would go slow with repeat surgery or alveolectomy. I would like to delay it as much as I can to find out if it's really progressing or if there's really a disease lurking there.
Dr. Neelam, your take on this, would you counsel the patient for a clearance of the inflammatory polyps and counsel him for an alveolectomy, or you would wait and watch till the patient is on oral posaconazole?
Sumit, your patient is basically presenting with numbness. Numbness means there is some neural involvement. I would really like to have a look at that MRI again. If I'm not mistaken, this patient would have involvement of the inferior orbital area.
Yes,
there will be some sort of disease there. And if we follow it through, I wouldn't be surprised if this is extending up to the foramen rotundum or the maxillary nerve area. Numbness is not indicating bone involvement. It's always indicating neural involvement. So I think as far as this patient is concerned, he definitely has to be counseled that we have to go in and remove that disease, which means a better clearance. Just doing this endoscopically in the sense with just a nasal fess, as we say, or endoscopic assisted surgery is not going to work. You're going to have to do a Denkers. You're going to have to most probably look at the retroantral area. The fact that he has a little bit of swelling on the cheek, I wouldn't be surprised if we look at the MRI images and we do see some extension in the pterygopalatine area.
That's clear. Dr. Neelam, the MRI reports of the patient, except the inflammatory reactive polyps in the maxillary sinus, there is no evidence of any disease of mucor in the maxillary antrum, retromaxillary, pterygopalatine fossa. But I completely agree with you. When we did him the first, there was a very minimal disease and it was just lying at the level of the infraorbital foramen and in the roof of the maxilla. And that's why he has this numbness, which is still persisting even in 2.5 months. So the question here is whether for his little bit of pain and numbness in the gums area and with the CBCT finding, should he go for an alveolectomy to an oral and maxillofacial? He has refused that. I'm not bothered about the polyps. I'm going to wait because I'm quite, messed up.
The alveolectomy is not going to solve his issue as far as the numbness is concerned. Like I said, the numbness is neural. It's not osteo. It's not bony. So how is the alveolectomy going to solve his problem of the numbness in the area? Clearing the maxillary sinus of inflamed reactionary polyps, I'm not sure. You're saying on imaging there are looking like polyps, but I wouldn't be so sure. I'd put in an endoscope, I'd remove a lot of that polypoid mucosa, send it for a biopsy. Again. And only if the HP tells me, yes, this is inflammation and reactionary, would I believe it. I'm not going to, the radiologist cannot give me a pathological report.
Okay.
The radiologist give me an idea that there is something there. But what is it exactly is something that visually and histopathologically I have to confirm.
So your take is a Denkers approach, clear all the polyps, send all the mucosa.
I'm not happy. I'm not happy that that maxilla is looking too full considering you've done a reasonably great job. Why is it still so inflamed? So I think I would like to go in back again, remove that entire mucosa and have a specific look at that infraorbital area.
Anyone would like to differ? Dr. Munjal, your take on this? Same?
I definitely would support almost like an open Denkers approach in this. And we have to take out the premaxillary bone. We have to follow the infraorbital nerve right back from the floor of the orbit down. And even the inferior orbital rim. That is commonly a site of concern, and the disease goes into the zygomatic bone from there. So these patients are difficult ones, as you seem to be pointing out, and this is a really problematic area. It's bony, all of this involvement. So I don't know, posaconazole, I'm not very confident with that also in the long run. I've tried Cresemba in these patients. I had to, because of the pain, which is constantly there, given tryptomers and things like that along with that. But yeah, your concern is mine. We are facing this problem, and I've seen the disease going many a times into the zygomatic process through this route. Yeah.
Great. And numbness will stay because it shows a neural involvement. One point, Dr. Neelam, how do you look at these patients in combination therapy? With ampho taken 10 days, posa for 1 month, still some numbness, pain, you are suspecting a progression of disease. Would you like to admit and put them on a combination therapy?
So it now differs. When we started out, we were putting them on combination from the primary reason that we didn't have amphotericin. Now we do have amphotericin. So all those who are getting admitted now are on amphotericin. With those patients of ours who are on oral postcanazole, and like this patient who may be at discharge, we are doing serum postcanazole levels in our institute.
That's rough levels,
So we do these serum postcanazole levels almost every 2 weeks. So that helps us to know whether it's just that he's eating the tablet, but whether the tablet is really working. So that's something that we are doing routinely. The duration of therapy, it's too early to say. Look, I mean, all of us really started dealing with this only in the month of April, March, April in a big way. I would just say that right now, out of all the patients, and we have, I think, a cohort of about 68 that we are following up right now. It's only in 2 that we have now stopped postconazole based on the fact that now clinically and radiologically, there's no evidence of any disease increasing. But most of the others are still on oral postconazole. But I would urge all of us to get the levels done, because it's sometimes amazing that these guys have been eating oral postconazole, and when you do the serum levels, it's like way below the therapeutic level.
That's right. So we got the trough levels for this guy, and it was maintained at, it was supposed to be at around 1. So the serum levels was about 1.21. And this is how, he said, okay, I am quite okay with it, and we'll see. One more question. What is the consensus, Suppose, like you said, 2 patients, you have stopped oral posaconazole. For how many months you will keep on getting an MRI for seeing the disease reoccurrence or the progression or seeing this, What do you tell to your patient?
We don't do so much imaging, Sumit. When they are in the hospital, yes, we are doing imaging, but on a follow-up basis, it's based on symptoms. So when they come for a check endoscopy, if I find something suspicious, or if symptomatologically the patient is presenting to me with a new symptom, would I send him for imaging? But as a routine protocol, every time they're coming for follow-up, we are not doing imaging. No.
Great. Thank you. We move to case number 4. This is a 67-year-old female, COVID recovered, diabetic uncontrolled. So she was admitted in the hospital for COVID for 10 days on oxygen, on steroids, kept for a month. She developed facial pain and stiffness in the area of the jaw after about 3 weeks of COVID. The vision was normal. Now, the course was that she underwent a surgery in another hospital, bilateral FES done, biopsy sent, mucor was isolated on culture. She received about 12 days of liposomal amphotericin B and discharged on posaconazole, probably because of the shortage of the drug. She again developed pain, jaw, palate, slight discoloration on the right side after 2 weeks of discharge, and was readmitted again in another hospital for second debridement done and discharged with 3 days of liposomal amphotericin B. Now, this is the clinical presentation. When the patient came to me, this was referred to me by a surgeon. And I saw the condition of the palate look like an osteomyelitic upper jaw to me. The mucosa was not very healthy. And we got the radiology testing again done, the CT scans, the contrast MRI done. So basically there was hyperintense signal in the area of the left maxillary, the right side ethmoidal area, abutting the lacrimal area, lamina area. The sinuses seemed to be clear, although there was some necrosis. We also got the CBCT done, and actually CBCT showed affecting both sides of the premaxilla. Both sides were affected, but the left one clinically seemed to be fine. And we went ahead and did inferior maxillectomy with debridement of the sinus area. We removed all the disease, and inferior maxillectomy was done. It was the mucosa was not healthy, so it was not preserved. The patient again received about amphotericin liposomal for about 14 days. So a cumulative dose of 5 grams she had received over admissions into 3 hospitals, and she was discharged on posaconazole. The limiting factor which happened was her renal function started to deteriorate, and it went up to 1.8. And we have been following up the patient. The patient is perfectly fine on Ryle's tube. We are planning an obturator, spoken to the maxillofacial surgeon at Max. Now, the concern is that the latest MRI still shows some amount of enhancement, residual disease, or, in the area of the infraorbital, there is loss of plane in the inferior rectus. If you can see, the medial rectus looks better. And there is, uptake in the area of the infratemporal, especially the pterygoid muscles. Now, the problem is that what to do in such cases. Dr. Munjal, would you like to take up how much of liposomal amphotericin B, looking at the age of the patient, the renal profile, Now, the latest MRI is showing uptake in the area of the infratemporal. Now, what to do about these pterygoid muscles, especially the medial, the lateral pterygoid, and the infratemporal area? How do you manage this?
Of course, these are functional muscles, and they're. I mean, we have done debridement if they're absolutely necrotic. We know that the maxillary artery in these areas is, in all probability, totally thrombosed, and it's not uncommon to do a debridement. But of course, if it's just a signal and it's an inflammatory signal, sometimes when you reach surgically, it all depends if the lady is still fit for surgery.
She's fit, but then but then they ask me, sir, how many more debridements?
Yeah.
What about the pterygoid muscles? What do you do?
Absolutely. Yeah.
If you see the picture post-op, I have shown you the palate after the inferior maxillectomy. The mucosa seems completely healed. We do endoscopy; it's all clear.
Yeah. So, absolutely. I mean, but considering the fact that you could only give liposomal amphotericin again if you start from really low dosages, like there is a sect in our hospital, especially the nephrologists, who do not agree with very high doses of amphotericin anyways, and
we gave her 5 milligram. We gave her 5 milligram.
Yeah, that's a cumulative, you said. But 5
milligram was a cumulative, but 5 milligram per kilogram per day was.
So that's quite a bit. So if she's 50 to 60 kgs, we are almost going up to 250, I think, in some situations. So even to arrest an inflammatory situation where the fungal signals, T2 suppression is still coming, you should still support some sort of amphotericin in her. Posaconazole, I'm not again sure if she has such a radical disease. Will it help? I'm not sure. So I would still go support low dose amphotericin in such cases. Secondly, if a little bit more of debridement can still be done, absolute necrotic material will not respond to any antifungal. So a little bit has to be debrided wherever you think it is possible.
See, on doing an endoscopy, and it doesn't look to be any blackish hard. It doesn't seem, but yes, on MRI, the muscle takes that signal.
So the inflammatory part, you don't have to, I think, at least I don't go after it too much. But the necrotic part, yes, I do.
Dr. Neelam, what would you do in such a case? How do you counsel these patients for how many further debridements, and how do you tackle the pterygoid muscle area?
Sumit, you said increased uptake on the MRI of contrast. That basically just indicates reactionary edema, which is inflammatory. So if the tissue is actually uptaking the contrast, it just indicates an inflammation or an edema. There's nothing that you and I have to go actively and debride in this case. One must remember that when one uses imaging, especially MRI 3 Tesla, it is known that there is an element of overdiagnosis also here. So let's combine our clinical, which is what you have done. You've examined the tissue, patient is comfortable, your tissue is looking healthy. I agree with Dr. Manish here. I'm not going to run after that edema of the pterygoid muscle. It's going to settle down.
Would you give these patients a combination therapy? Maybe admit them, like Dr. Munjal said, liposomal amphotericin low dose for some days and add a posaconazole to this?
From what I understand, you've already given this patient a cumulative dose of about 5 grams. But from what I understand from the infectious disease specialists now is that they really don't look at cumulative dose. They are looking at giving liposomal amphotericin beetle as much as patient can tolerate. And we have patients who have even received up to 6 to 7 grams. So it's basically how much this patient can tolerate. And if you're telling me that her renal function is getting a little haywire, then I'm going to leave it to the consensus of the infectious disease specialist and the nephrologist or the physician to decide on that. Frankly, I'm not going to be intervening into that. But if there is an issue whereby we cannot give this patient liposomal amphotericin B, I would definitely like a combination of posaconazole to be added.
So how do you follow up within clinically doing endoscopies, and would you like to get frequent MRIs done, maybe one in 3 weeks time, and see the disease spread? No?
Patient is absolutely asymptomatic, Sumit. That's what you're telling me.
Patient is fine now, yeah.
Yeah. So, I mean, why am I subjecting this patient to repeated imaging? Please, like
I tell
I
you the
say
reason
again.
why. I tell you the reason why. So the patient is asking me a question that when they can get the prosthetics done, because they don't want to put a lid onto something where, because they read the report also. So I'll come to you, Dr. Aditya, about it. So my point is that as per you, there is we should leave the patient, do an endoscopy, do a follow-up.
All our patients get a partial obturator fitted almost immediately. They get a temporary prosthesis put in. I mean, I wouldn't be sending a patient home with an Ryle's tube. So, you know, immediately after we do the surgery, within a week, they get a temporary prosthesis put. These people are on oral, you know, feeds. The reason she wants an obturator or a prosthesis is because she wants to eat. And the Ryle's tube is what's irritating her. So you can get a temporary prosthesis put in. You're off the RT. You have something whereby you can still keep examining the cavity. There is no hurry to get a permanent prosthetic put in now. And that's where I think Dr. Chaudhary and Dr. Murthy have already said there is no reason to hurry. But she definitely wants to eat. I can understand where she's coming from. Yeah. So get a temporary prosthetic put in, and why imaging again and again? Wait and see. If she develops a symptom, then we go ahead with that.
Yeah. Okay. Great. Great. So, you know, Dr. Aditya here, you know, when can you plan this palatal prosthesis? Like Dr. Neelam said, temporary can be, the patient can be sent home with the temporary prosthesis immediately. And because not only the feed problems, the speech problems are also there in such patients after inferior maxillectomy. And would you do same stage or versus a subsequent reconstruction?
Okay. You know? When this whole thing blew up in our faces this time, around about the last week of April, probably the end of the third week, we had so many numbers that we could not do what we generally do, which is take an impression before surgery and give them a feeding plate right on table. So they get, if there are 4 teeth left on the opposite side, even if you have had a subtotal maxillectomy, the clasp will hold on. You put in a bib pack, you put in a plate. Of course, the first 3 or 4 days, they will be on a Ryle's tube. Then give them clear fluids. And that is called a feeding plate. Point number 2 is once the feeding plate is in, things are fine. They get an interim prosthesis with teeth. The teeth are not going to chew, but they will give some amount of cosmetic comfort to the patient, and it will separate the nasopharynx and the nasal cavity and the sinuses from the nose. So that temporary prosthesis is a feeding plate, and another temporary prosthesis is an interim prosthesis. And we are talking, yes, the speech is going to be a bit of an issue, but you'll be surprised how quickly the patients adapt to it. And the proprioception is not going to be a problem. They can speak they can be quite articulate with these things. Same stage versus subsequent reconstruction. I'm not terribly sure what you mean by that.
That question is for Dr. Sunil Chaudhary. You were mentioning about that most of these palatal defects you would like to be a little up so that you leave space for the obturator to fit in. Sir, how do you plan these inferior maxillectomies? Some kind of flaps, pedicle flaps, rotational flaps? How do you see these cases, you know, for reconstruction?
So I think we need to really see a lot of these patients, if the defects are very small, I think the prosthetics actually can do quite, you know, good as well. And a lot of these patients may not be medically very fit to have the procedures as well. Very small defects, you can actually do reconstructions with local flaps. As you know, you can if you think the facial artery is all right, you can actually Doppler it. You can even do a nasolabial turn-in flap, and it can be an islanded flap, so it can actually cover some of these defects as well. One could do a temporalis flap as well for some of these cases as well, in case if you want to do a local kind of a flap there as well. But overall, I think if one wants to have a proper bone there, then one could do a fibula reflap. I would usually stage them, as I said. You probably wait for about 3 months before they're actually fit to have another major surgery. And fibula can actually take implants as well. So you could actually plan it with your maxillofacial colleagues, and you can actually do a good job as well. But yeah, I mean, it's patient has to be given options. It's not that one technique is superior to the other. It's just that a lot of patients would actually do quite well with the prosthetics as well. And I'd be quite happy if, the patients actually go through the whole, rungs of the ladder and they reach us when people think that, yes, reconstruction would be superior than having a prosthesis.
So looking at, because these patients have already got too many surgeries done, they're quite frustrated staying in the hospital. If I vis-a-vis value one prosthetic reconstruction versus one vascular reconstruction with the plastic and add on prosthesis with the teeth, Dr. Murthy, your...
Okay. I again agree with Dr. Chaudhary. Very quickly to make it clear to the audience.
In this patient, actually, looking at the defect, just an inferior maxillectomy, not a complete maxilla defect.
Yes.
Dr. Murthy, after this conference, I'm going to call you and we're going to have a cup of coffee together. Maybe either I can fly to Bangalore or you can come to Delhi.
Or something stronger.
Well, I don't go beyond coffee. So that's it.
All right, then coffee.
Count me in also, Don't leave the ophthalmologist.
Oh, so sorry. Sumit sir.
Sure, sir. Yeah, Dr. Murthy. Yeah.
Sumit sir, very quickly, he touched upon a very tender nerve, which I get upset when a lot of people are looking at something very complex. He said local flaps. You could actually just advance the mucosa. Everybody could do that. You could do a FAM flap, an exceptionally useful flap. A slightly smaller defect than what you have would be amenable to a FAM flap. Then would be the nasolabial, which is the cutaneous counterpart of a FAM flap. My personal favorite here is going to remain the temporalis flap, provided Dr. Dhawan doesn't want to use it for his orbit. Sometimes he wants to plug the orbit with the temporalis and put a skin graft over it. All of these things, any one of us probably could do. But if a slightly bigger defect, you want teeth on bone, you could consider a fibula, but I think the defect is too small for a fibula. And what we would consider is probably zygomatic implants, stock zygomatic implants, which would be less expensive than printed ones. And I would do it a lot later. This patient will benefit from a tooth bone obturator probably for the rest of his or her life. So I would actually offer a tooth bone obturator. The only thing with a tooth bone obturator is that the surgeon has no role in it. So if we put aside that ego, I think this patient will benefit entirely from a tooth bone obturator forever. I think Dr. Sunil Chaudhary just said exactly the same thing.
That will be more concise and one-shot treatment for the patient, right?
Absolutely. Right. And you could always go back and do a flap. This doesn't preclude a flap.
You don't burn your bridges, and I think the patient has a choice. And I'm more happy for these patients to explore the simpler options first and come to us as a last option.
Great. Thank you. Now, this is a very interesting case, and I would like, Dr. Dhawan, your comments on this. So this is a 44-year-old male, COVID recovered. So he complained of jaw pain and headache 2 weeks after COVID infection. He was, this patient is from outside Delhi, and MRI suggestive of mucor and FES and debridement done at the hospital. Biopsy and fungal culture, both suggestive of mucormycosis. The patient took 3.15 grams of amphotericin B, and he was discharged on posaconazole. Now, in the subsequent course of disease, the patient's son, educated man, and he got his high CRP levels. He got a repeat MRI done, which showed a residual disease in the orbit. He took an opinion in the local surgeon there, and who asked him to get the repeat debridement done because of a residual disease in the orbit. The patient came for a second opinion, and endoscopy was done. The area was granulating well, and swab was taken, which showed a septate hyphae. So the patient was started on voriconazole. The patient was clinically stable and again seen after 15 days. But unfortunately, while the patient was taking voriconazole, and he was actually taking the posaconazole also, when he had a sudden decrease in vision on 6th of July, and the PL came negative. The swab was suggestive of aspergillosis. He was started on voriconazole and the posaconazole was stopped. And again, since the disease increased in the fresh MRI, I'll just show you the picture. He was again started on posaconazole. So too much flip-flop back. Now, this is the picture of the patient. Little proptosis, little bit of ptosis, watering of the eye, eyelid edema. and its PL is negative. And the MRI shows disease is now sitting at the orbital apex, residual disease in the orbit, pterygopalatine fossa, retromaxillary area, superior orbital fissure involved, right cavernous sinus is bulky. How do you approach? First of all, I'll ask the ENT colleagues for the plan of action for rest of the disease, but how do you say about the orbit? 1 month after the patient had mucor, was on amphotericin, posaconazole, and then developed a sudden decrease in vision.
So in his case, of course, there's orbital apex involvement is there, and you can see the disease obviously sitting at the apex now.
Yes.
And so there's no other option left but to do the exenteration for this patient. We have to go ahead with that. There's no way to conserve the eye. The vision is already lost. You can see the visible disease there at the apex. If the disease was not there, we could have thought in terms of just a vascular involvement. And in that case, maybe intraorbital injection of amphotericin B could have been considered. A patient could have been followed up. But there's an obvious sign of a disease sitting in the orbit near the apex. We have to go ahead with the exenteration.
So, correct me if I'm wrong. Suppose a patient comes with PL negative on day 1 in the morning. The MRI shows no intraconal involvement, but there is just a compression and a disease sitting in the extraconal space, not infiltrating. Would you consider these patients for retrobulbar injections and think about getting the vision back?
We will consider them for retrobulbar injection and also follow it up with serial imaging to see whether the disease is progressing or not progressing. If disease shows sign of progression, again, we have to go in for exenteration.
So in this case, orbital exenteration would suffice and remove the disease, right?
Of course, with all the systemic treatment to go on along with that.
Now, do you think that removing the orbit or exenterating the orbit is going to stop the progression of disease from the orbit to the brain? Because the cavernous sinus is almost a little bulky. So we are sitting at just at the brain level.
So we at least remove the bulk of the dead tissue so that the systemic antibodies can penetrate in the healthy tissue around it. So we have to remove the bulk of the disease there.
Okay. Rahul, can I have you?
Yes, sir.
Okay. So you have understood the case?
Yes.
Right.
Yes.
So the family is with you. The family is asking, you have to counsel the family for the surgery. Would you like to go for a repeat endoscopic sinus surgery, functional endoscopic sinus surgery, debridement, do a Denker's approach, do a complete medial maxillectomy, clear the disease, or you would like to opt for an external approach and along with an oculoplastic surgeon, complete in toto, remove the disease?
So I agree with Dr. Dhawan in terms of the orbital exenteration is the minimum that is required here. And I would like to debride as much as I can clinically. Whichever tissue looks non-viable has to go. Endoscopic or external depends upon how much of the skin involvement is there. And if I'm not
It is not involved. See, there is just a little infraorbital edema. But if you see the involvement of the disease from an ENT and from an ophthalmology point of view, you would be more, we all know that for mucor, we have to be a little aggressive surgeon because the best chance is to remove the disease and then put them on liposomal amphotericin B because dead tissue in the body, liposomal doesn't act. So you would prefer an endoscopic versus an open approach. Now,
so if I'm able to remove all the dead tissue endoscopically, I would continue to do endoscopically. However, if I feel if I'm not able to do, then I will go ahead with the external approach and clear out. I mean, importance is to clear the dead tissue out, like you rightly said. And the approach depends upon how much of the disease I see intraoperatively. If the tissue is bleeding, then I'll not be very aggressive. But I will counsel the patient that this is a patient who has received a good amount of amphotericin, a little suboptimal, was on therapy, and still the disease has recurred. So my prognostication will be a little different than say if I'm operating him per primum and if he's presenting for the first time. In a treatment naive patient, I'm a little more hopeful, but in a patient in which the disease has relapsed on treatment, we'll start the systemic therapy, but again, the prognostication would go down significantly.
Right. Dr. Manish, your call, endoscopic versus external approach, and how will you counsel this patient?
First of all, I would like to, rethink about even the exenteration right now in this case. You have to tell me one more thing, whether the patient is having any ophthalmoplegia, any restriction of eye movements.
Right now, no
nothing like
ophthalmoplegia.
that.
No ophthalmoplegia.
So we do have an apex involvement, but it is not really. It looks more like a compressive disease rather than looks like an invasive disease. Well, I don't know. I mean, we have done so many orbital decompressions, medial, inferior. This disease looks like medial orbital apex slightly superior, then quite a little bit of inferior going almost lateral. So I don't know. It's something, if the patient is moving his eye and looking at you, it has been already 6, 7, 8 weeks of treatment for him. He was doing well, as you said, and then now this thing has happened. Maybe just go in to the through an endoscopic route, take off the lamina, the fat, follow the medial rectus up till the orbital apex, take off all the debridement, and do the lower part also. If that can suffice, I don't know. Maybe spare him. Maybe spare him the exenteration. Yeah.
Dr. Neelam, your thoughts on this patient, endoscopic versus open, and involving exenteration or not?
So it's going to be a lot of counseling that I'm going to have to sit and do with the family. But I do agree with what Manish is saying. When you look at the patient's eye per se from outside, yes, there is a little bit of edema, but it doesn't look like one of those eyes which is chemotech and the one where you immediately say, yes, I want to do an orbital exenteration. So I'm going to talk to the family. Of course, I would like to look at the images more in detail as to whether I think I'm surgically equipped with the knowledge and the instrumentation to be able to endoscopically do an orbital clearance. So I'd like to look at the images again. I will talk to the family and say, look, I'll give you one shot. I'll try and do an endoscopic orbital clearance. We'll clear the disease. But if in spite of this, there is an issue, then you are looking at the eye going, or an orbital exenteration. The reason I say this is because there is a mindset, at least in a lot of physicians, and remember, we are a team that's handling this patient, and they have a feeling that if a disease involves the orbital apex, it's like gone to the brain.
Yes.
And I've had issues here where I'm trying to tell them that, look, all this is fine, but you are dealing with that in the form of, medical treatment, and let's give the patient a chance. But unfortunately, sometimes they will talk to the family and they will give the family the feeling that we as surgeons are not doing a complete job, and that's where the disease is extending. So it's very important that we talk to the family and we say, look, we are trying to save it from an orbital exenteration, but in the event that I can't do a complete endoscopic orbital clearance or I'm not happy, then we are looking at going at the orbit going. But I would try an endoscopic orbital clearance first.
Tell me one thing. The disease is not going to harm as much as in the pterygopalatine fossa or in the retromaxillary area. If we let the disease be in the orbital apex, don't you think that the chances of disease spreading in the cavernous is already bulky? We are actually allowing it to sit there and traverse to the brain. And once it goes to intracranial, then he has already taken amphotericin at 5 milligram cumulative dose given. Then intracranially, we are going to target 10 milligram per kilogram minimum. So how do you justify that?
Anyway, your dose has gone up. The minute it has come to the orbital apex, you are treating him as intracranial. So your amphotericin dose is now anyway 10 milligram per kilogram body weight. Whether you do an endoscopically. So when I say endoscopic orbital clearance, it means exactly what Manish said. You remove the lamina, you open up the periorbita, you see all the dead tissue there, clear it up and go as much into the orbital apex as possible, keeping the nerve intact. So like I said, this is one step away from orbital exenteration. And if you're not able to succeed after this and the disease still progresses, in the sense maybe the patient develops some other symptom, then yeah, you've given it a chance, you've given it a go.
So maybe you will explain to the family that he might need 2 more surgeries.
Yeah.
He might need. So there is an interesting article which has been published recently, which says that even doing an orbital exenteration may not prevent it spreading to the brain. And
that's obvious, Sumit. That's obvious.
What exactly point you are making into it?
Agreed, but that's exactly what I'm saying. So the minute you say the disease is in the orbital apex, when you look at the best orbital exenteration that we do, we are not able to address that part of the nerve and the disease which is already entering into the cavernous sinus. There's no way we're doing that. So, you know, whether you and I do an orbital exenteration or do an endoscopic orbital clearance, it frankly depends on how we are as surgeons and how equipped we are. What I'm seeing now is, in the name of endoscopic orbital clearance, is that there's a lot of, you know, unnecessary surgery happening, which is not enough. So I think that is something which, as a surgeon, you and I have to take the call of how much we can do. And if in doubt that you can't do it endoscopically, then I agree with Dr. Dhawan, just go right ahead and just get the orbit out.
So if you have your surgical skills right, and you would try to opt for a complete endoscopic clearance,
I would give him a shot.
If it fails, then maybe an exenteration.
Yep.
One more point in this patient, Dr. Murthy, I'll come back to you. Just give me a minute. The patient was proven mucor on biopsy and culture. These patients often come back to us when they have stopped the treatment or they are on oral posaconazole. Is there any role of taking nasal swabs and doing culture from the nose? Because the patient it came out as aspergillosis. Now, literature says there is a lot of mixed fungal infection happening into the nose. Once you have a proven mucor, you take it as mucor, you don't treat both, because patients on mucormycosis treated with voriconazole actually deteriorate, then vice versa. So would you do culture swabs or, tissue biopsies in the subsequent post-op visits? Does it play any role?
Not routinely, but if I have a suspicious lesion, like I have a necrotic exchar or I have a blackish appearing mucosa, when I put in my endoscope, I will pick up that tissue and send it. But would I do it in a completely healthy looking mucosa when I do a post-op follow-up? No, I wouldn't. So not as a routine, but yes, if there is any suspicious looking area, I would take a biopsy from there.
Dr. Manish, you are seeing a lot of patients of mucor. Are you doing these nasal swabs for follow-up endoscopy? Sometimes the patient asks you that, have I been treated of this mucor? Is it still in my nose? Do I have some other fungal infection in my nose? Do you take these cultures or swabs?
I think repeated cultures, repeated MRIs also, Sumit, frankly, is only going to make our lives shorter. I'm telling you. It's so, as you said, the relatives go and tear you apart, even with a little bit of MRI signal inside. And I think it takes you nowhere in terms of treatment. So I am generally very allergic to get any sort of post-operative serial programmed, even endoscopies, sometimes there's such wide cavities, they're sitting like 5 patients of mucor sitting outside post-op. I just want them out of my OPD. I just bring them in, see the white speculum. It's looking fine. Please go home. It's like that usually. And if they're symptomatically fine, I don't want to touch them. But I want to see them routinely. That's what I want to do.
Follow-up is important.
They should keep on meeting me, telling me, because that makes me easier. And if they are getting MRIs done, I completely freak out, on their own, especially some of them try to and get cultures and all. I'm totally against it. I don't think it takes me anywhere. Yeah.
Dr. Aditya, you want to make some point?
Yeah. Yes, I think I just wanted to reiterate 2 points Dr. Vaid and Dr. Dhawan made. The idea is to reduce disease burden. So whether it's done endoscopically or you do an open procedure, so long as that end can be achieved, that has to be done. So we have to attempt to reduce disease burden. And point number 2, one thing we have realized, other than the first 3 weeks, the first 80 odd cases we saw here, intracranial spread is no longer a death knell. This is what we've realized. And in our experience of 220 odd cases, the first burst of cases was terrible. The mortality was close to what was published as pre-COVID mucors. Later on, it was quite amenable to treatment, including craniotomy, excision of the neurosurgeons went and excised their abscesses, and the patients did far better than we thought they would. So it is not a death knell. If that would probably help for counseling. And so long as we stick to the point of reducing disease burden and fungal load as much as possible. Whatever has to be done, whether taking out the eye or endoscopically doing the same.
Right, right. Rahul, you did mention about using isavuconazole and combination therapies. Anyone in the panelist for such cases, would you counsel the family for maybe a combination therapy or maybe starting on isavuconazole? Anyone having experience in such cases? Rahul, you can take that question if you are.
So, I mean, we started using isavuconazole more as, a no option remaining when the drug ran out. And we have seen in a lot of patients that we have got good response, even as a monotherapy, even where we have not been able to use amphotericin at all. Just like, we have used probably 1 or 2 days of amphotericin, the drug ran out, we had to start on isavu as a primary drug and a single drug, and we have got good response. So I'll be very tempted in this patient to add on. It's been recommended as an A1 therapy by the global guidelines. So, and I mean, the literature is a little not that supportive so far. We don't have a lot of data. There is a vital study which supports the use of the isavuconazole, but we have seen a lot of, I've had 8 patients on isavuconazole so far. Out of that, we have had, apart from 1, we have had no disease progression in about 7 of them. Okay. So only in 1 patient who was bad, we have had a bad response. Otherwise, we have had a good response. And I would counsel the patients if, and again, it will be the decision of the physician and the infectious disease specialist for the combination therapy. If the patient is able to tolerate it in this patient, we'll go ahead with a combination of amphotericin with isavuconazole in this patient.
So, like as you said, I also searched the literature and looking for combination therapies, recurrent mucormycosis. So every article talks about one thing is that aggressive surgical intervention so early to remove the disease, reduce the burden of the disease in the body. So there is no definite data for combination therapy, though some authors have mentioned use of polyenes with echinocandins or azoles in salvage treatment. Now, I found out 2 very interesting studies. One was from International Society for Human and Animal Mycology, where 2 big studies, 106 patients with hematological malignancies who developed mucormycosis. Now, they gave a salvage treatment proposed by EC-IL-6, the combination of amphotericin and capsofungin or posaconazole. And they said that no improved outcome was there. In contrast to a 41 patient study, retrospective study, which showed that combination of amphotericin and capsofungin does work. Looking at the ECMM guidelines, what they say that isavuconazole is a recently developed triazole and with a wide spectrum of antifungal. And there's a vital trial where 21 patients with mucor received isavuconazole 200 milligram once daily. So they found the results to be equivocal when they were given amphotericin or they were given isavuconazole. So I think we need to have more data on this. We need to work up these patients. And another multimodal surgical and medical treatment trial where they also said that they did not observe improvement after 3 weeks of antifungal monotherapy. However, combination did much better. So maybe for recurrent cases, for residual disease, where we have already done so many debridements, maybe we can think about combination of these drugs. I don't have an experience of isavuconazole. It's a very expensive drug. It's not easy to procure it and give it for patients for a long-term therapy. I think Dr. Manish, you were giving in Gangaram for some days, and thank you.
But so just a point, in terms of cost, it is much cheaper than the liposomal amphotericin B. I mean, even though it is expensive than posaconazole, I mean, it comes out to be around 2 lakh rupees a month. And so, I mean, still can be considered as an effective option, especially when you're giving liposomal.
Dr. Neelam, would you consider isavuconazole as a solitary drug or a single therapy drug for these recurrent cases?
No experience, Sumit. We didn't have it available at all. So in our case, it was mainly amphotericin B and posaconazole. We really didn't use isavuconazole.
Okay. So finally, we are coming to the last case discussion for the panel today. A 64-year-old female, COVID recovered, diabetic control, took steroid dexamethasone. That's interesting. She took Dexa 32, 16, 8 and 4 milligram for 14 days at home. And she couldn't find a bed during the COVID times, decreased vision after 24 days of being COVID positive, ptosis of the right eye, PL negative. She had pain, jaw right side. Now, MRI was done, which shows thrombosed right supraclinoid, clinoid ICA, aneurysm, pansinusitis. She was admitted in an hospital in UP, and FES and debridement done with orbital exentration was done. Biopsy showed mucorales orbit invasive mucormycosis. Culture shows Rhizopus species mucorales. She was put on liposomal amphotericin B for 10 days, discharged on posaconazole. Again, the story that inadequate supply, amphotericin B. The course of disease, when she came to me, you can see the right palate, it is necrosed. It has started to get necrosed. You can see a classical differentiate between the right and the left. So palatal necrosis was there. MRI, PNS, orbit and brain suggestive of lacunar infarcts. In the temporoparietal, thrombus petrous, ICA and left orbit was normal. CE MRI suggestive of residual disease and progressive disease in PNS, right maxilla and right alveolar arch. So we did the repeat debridement done, discharged. The mucor rat still continues. You know, she took amphotericin for about 17 days. She was admitted in the hospital till her renal profile started to dip down. The creatinine started to rise. She was again hydrated well and discharged on posaconazole. It's about a month on the posaconazole, but the latest MRI again shows a lot of enhancement in the area of the retromaxillary in the pterygopalatine fossa. You can see in the picture the entire orbit, this part infratemporal is clear, but the alveolar process of the maxilla in the area of the right maxilla is showing involvement. So is a little bit of left one. This is the picture of the patient. It is granulating well. The margins are healthy. And she used a temporary obturator. She was not very comfortable, lot of crusting. She has this necrosis of the eye. The skin is also getting necrosed now. She's planned for reconstruction. And, patient has received cumulative 5.5 grams. And now MRI is showing no as such progression, but the pterygoid muscles are affected. Patient is discharged. Reconstruction. Dr. Dhawan, in such a case, you have seen the eye status. You have seen the condition of the skin. How much time will you wait? What all things you will keep in mind before planning eye reconstruction in such cases?
Siddhi, I would like to go ahead with do one more debridement of all the necrotic tissue which is there. Wait for it to become healthy. And then we don't really necessarily need to fill the entire orbit. We can go for a partial thickness skin graft also. Let it heal and use prosthesis to cover that up.
Okay. And, timeline would be once the margins heal up quite well.
Yes.
And they are granulating. So I am doing a regular endoscopy, cleaning all the crusting every week. The patient is visiting me. Dr. Manish, I clear up all the crust. I know it's a terrible job. It takes me half an hour to clear because unless I remove the crust, the granulation tissue is not going to come in. And if it will not heal, we can't plan any reconstruction. And Dr. Aditya, would you start working with the eye surgeon simultaneously and plan your reconstruction? Or you would prefer him giving her the artificial eye first and then you plan for the palate reconstruction? I can't hear you. Please unmute yourself.
So long as his initial debridement is over and he's going in for the final reconstruction, I see no reason why the patient has to go under the knife twice and has to be pumped full of gases 2 times. I would go ahead at the same time. The only thing I would want to know is whether they want a temporalis. Here, my primary thought would be to use temporalis to reconstruct the palate, because there is absolutely no soft tissue, and just an implant bone prosthesis would find it very hard to give a good seal. So that would be the only concern, bone of contention between me and my oculoplastic surgeons here.
Dr. Sunil Chaudhary, can I have your opinion here? Seeing the post-op cavity, you would plan some kind of a flap in this. Sir, are you there?
So again, I think it could be a mixture of techniques depending on what
defect. It's a very big defect. You have the tongue beneath, the whole of the eye. Medially, there is no septum. You just have that model roof.
Yeah. So I would actually go for a single stage microvascular free flap, because that would actually fill up the entire cavity.
Okay.
It would reconstruct the palate as well, and it would actually fill up the orbit as well. I've got cases I've shown that as well. But I would just go for if the patient is otherwise fit to have a major surgery, I would definitely do that. If the patient is not fit to have a surgery, then I would agree with Dr. Murthy. I hate to agree with Dr. Murthy on everything, but yes, I again agree with Dr. Murthy that we just do a temporalis flap for the palate and then do some sort of a prosthetic for the eye. Yes. So it would depend on the patient. Yes.
Dr. Neelam, again, I would say that seeing the MRI, see, more than the doctor, more than me as a treating surgeon, the patients are so keen to get this post-op MRI. Like Dr. Munjal rightly said, even we don't want every time they come with an MRI, they come with a contrast image, they discuss with the radiologist that, sir, there is still some enhancement in the pterygoid area. Should we go ahead with the reconstruction? It's about 2.5 months. It's a very difficult state to explain to the patient. And the reconstructive surgeon asked the primary surgeon, sir, you are good to go. From your side, is everything clear? Should I start my recon work or not? So I think we are in catch-22 situation, what to do. So how do you take this?
I always tell a patient, I'm not God. Given the limited knowledge that I have, given what I have in front of me, I think you're good to go. I'm not seeing any active disease process there. If any patient asks me, am I 100% sure? Can I give a 100% guarantee? I say, no, I cannot, because that's my limitation as a human being. I think somewhere the onus that we choose to take on ourselves, that we should have the answers to all questions, and we are the ones who must give the patient this guarantees, has to stop. We have to tell them, look, this is what we are seeing in front of us. This is what I see of you as a patient. And given what I have in front of me, I think you should go ahead. That's what I would do. In this particular patient, however, I would really talk to the relatives about that in ICA. There is a huge thrombus which is sitting there. And I think that's something that you need to really talk to the family and counsel them about, because you and I somehow as ENT surgeons are just kind of focusing on that little enhancement of the pterygoid. We're missing out that big thrombus sitting there.
Yes.
And it's imperative that you tell the family that, this is something like she's sitting on a time bomb. And it would be a good idea to get a neurosurgeon onto the team and just have an opinion there, because that's something that can really come back in your face. And I've had one patient where the patient did develop a hemiparesis. So that's something that I would maybe add on.
That's a point taken. Right. Dr. Aditya, I would like you to take through some of your, few of your slides, and maybe if you have time, Dr. Chaudhary will just take 5 minutes to show some of the local reconstruction flaps, which can be handy and which we can think. So, Dr. Murthy, can you please explain how do you plan this zygomatic implants and 3D planning with drill guides? So how do you rehabilitate so that the audience can get a fair idea that reconstruction is actually very beautiful? But let me mind you, it's very expensive, very, very expensive.
Yes. Can you go back to the OPG in the last slide?
Yeah.
A very quick look will show you that this is an osteotomy at the level of Lefort 1 osteotomy. Well, he's lost the maxilla from a high Lefort 1 level, which is probably just below the infraorbital nerve, and right back to the pterygoid plates. I have separated the pterygoid plates, and at this point, it automatically precludes my placing any kind of an implant at anywhere other than the zygomatic bone itself. Now, this chap's, the issue here is going to be retention of the implant. This person's palatal mucosa was entirely preserved. So there is no communication. And this precluded automatically the use of a fibula here. A fibula would have been perfect. I would, if a free flap had to be used as an alternative, what I would have preferred was a fibula to be placed here and secured to the zygomatic process. And that's what I think Dr. Sunil Chaudhary would do. And he would secure it higher up than the alveolar level, so that there would be space for me to put in my implants and my teeth. If you put it further lower down and be reconstructed, the lower jaw would be pushed below, and he would have perpetual temporomandibular joint disease and inefficient chewing. Considering that the mucosa was intact, we chose to have zygomatic implants. Mind you, generally you would like to have 2 zygomatic implants on both sides.
Can I show the next picture? Probably you will explain better.
Yes, please.
So you have 7 minutes to explain, and then maybe 5 minutes.
Yes, I'll only speak faster then. Yeah. At this point, I want to have a disclaimer. These implants are put in conjunction with my implantologist. I'm not that clever. And all the beautiful work you see go to Dr. Jayant and Dr. Preeti, my prosthodontist. The planning, of course, for this one I did along with Dr. Jayant. So what you do is you have a 0.625 millimeter slice CT scan, a high resolution CT, and any company you would want to use would show you this one and what you see here, and you would print out a skull, and that would give you your defect. At this point, you would sit remotely with the chap who is having the software. You could do it yourself if you are very clever, but I am, as far as I'm concerned, I'm a computer illiterate. I can do nothing with that. You sit with him and he will take you through the positions and the planning. And if you go on to the next slide, and we'll come back to the slide. Yes, this is how the defect would look. And based on the planning, you would pop in implants basically in this direction. This you see, there has to be, the implant has to be entirely within the body of the zygoma. At the same time, it is counterintuitive. It looks almost horizontal. But eventually, there are going to be attachments which are going to ensure that there is a bar around it, which will allow for teeth or a prosthesis to be placed. Can you go back to the previous one, please? Yeah. All right. So once we decide what direction and what length the implants are going to go in, these implants are available as stock implants of varying lengths, and you can pick one off the shelf. And the biggest problem here is once you open, as you saw in the next slide, you cannot eyeball it, because what you see on table is very different to what you would have planned on the computer. The sensible thing would be to have drill guides. So these drill guides are printed out to sit flush on the zygomatic bone as is seen, with a preordained drilling positions. And they have 2 millimeter holes for screws for you to stabilize them onto the zygoma. So you stabilize them, and after it, it's pretty much plug and play. Once you stabilize them as you want onto the zygomatic bone intraoperatively, you just take the zygomatic implant and pop it in. That's a bit too technical to explain how that second part is done, but suffice it that it is reasonably straightforward compared to what all we are speaking. The trick here, the devil is in the planning. So as long as you plan it well, next slide, please.
Okay. So this is how you plan it, and this is the pre-op and the post-op picture, right?
Correct. So I took it as a compliment to my prosthodontist when you asked me the post-op picture for the picture on the right. So that is the post-op picture actually.
We have to show the post-op results. That is important.
Absolutely. And this is how it ends up. And this is an orbital reconstruction. The same maxillofacial prosthodontist did. This is a mucor from before the COVID era. And we did not do proper lid sparing orbital exentration. We left the lashes in place. And this is the lollipop you see in the middle is the impression she took of the orbital cavity. And we gave a very, very nice orbital prosthesis here. The problem here is that this chap came from his village and he just could not figure out. You have to give a suction cup to take out the prosthesis. He has to dig a suction cup right into his eye, the one which the prosthesis, and pull it out. And that is the best way to take it out, because as it heals, he will not be able to get any instrument to tease it out. So eventually, because he could not put it in and on, it started fibrosing. And now he actually is back to spectacle prosthesis, which is a very, very poor replacement for a result like this. Next, please. Yeah, routinely, if we have any bit of periosteum left, the advice would be to pop in a skin graft. However, after mucors come down and we figured out how we operate on mucormycosis, mostly leaving back most of the periosteum is not an option. And in this case, we turn in some temporalis muscle and put a little bit of a skin graft onto it to accept the prosthesis. Next, please. Yeah. So palatal reconstruction, big enough defect, a nasty palatal defect. He loses a fair bit of the defect, and you can see on the right hand side that it's a big defect. It can be dealt with in multiple ways, but it's not so big that we thought that he would desperately need any kind of a flap cover. Next, please. And this is the 3D printed plastic model, and this is what my colleagues planned. This is how they wanted. They got this dental position printed based on his preoperative scans, and the right hand side shows your zygoma implants holding the bar attachment. On the left hand side of the patient, there was not enough space to put in a second zygoma implant, and we made do with one. Apparently, this is not ideal, but it worked for this patient. Next, please. And this is how it would look. This is the planning phase in the clinic, where wax up and modelings are done to ensure the position of the bar. And this is the bar which is going to hold the final prosthesis. Next, please, Dr. Mrug. And this is a bird's eye view of the planning. Even the cast has gotten 3D printed. 3D printing is a boon if you are willing to spend on it. And this is how your final prosthesis looks on the cast. Next, please. Right. And based on this is the final prosthesis. And the lower right photograph shows how it sits. Next, please, Dr. Smith. And it's a very, very happy camper here. And I do not regret that. I was very tempted to put a temporalis in here because virtually all of this work, I had no role other than taking credit for it. So I was a bit disappointed when they wanted to put in a prosthesis, but my prosthodontis was very firm, and rightly so. And I learned very, very good lesson that this is probably the way to go in most of these circumstances.
So I would just say that, I would thank all my panelists, such a multidisciplinary panel I had today. I would just say that, with Mucor, creating so much of wrath in the last about 2.5 to 3 months, we are still getting patients with recurrence, recidivism, with the complications, with the planning for reconstructions. We should treat the disease aggressively in its first go. It's very important. Involve multidisciplinary team for a better outcome. Plan things from day one. Don't get lax after initial improvement. All of us have seen, we feel joyous that we have removed the disease. Fungus may come back more aggressively. And get follow-up MRI scans to see disease progression. I would not say a very frequent one, but yes, do take it. And finally, thank you to all of you. Dr. Chaudhary, we have 5 minutes left and we would be happy. Dr. Vijay, can we just have 5 minutes? Maybe some good flap reconstruction for local. Can we see that?
Yeah.
So we have finished on time. We have 3 minutes left. Dr. Chaudhary, you can just share your screen. I'll stop it and then we can have questions.
Yeah, if you just allow me to share the screen.
Yeah.
So I'm just going to show a few cases. I might skip some of the slides. This is basically a small palatal hole, and as you can see, one could actually use a nasolabial flap here, which can be islanded completely. This is a superiorly based nasolabial flap. You can actually doppler the vessel, and this can be turned inward, so it can be a single stage procedure, as you can see here. Dr. Murthy was talking about the fan flap, and the fan flap, as you can see here, can actually fill up some of these alveolar defects. The good thing is that, this is actually one of the oncological cases. See, the techniques and the way we do these cases is purely, it's exactly the same as we would actually treat the oncological cases. However, in oncological cases, we are doing a single stage immediate reconstruction, whereas here we are actually doing a delayed reconstruction. But overall, the strategy is almost the same. It's mainly a combination of the various kind of maxillectomy and orbital defects. And this is a nasal defect, and you can actually use a forehead flap. You can see in multiple stages, in 4 stages, you are able to achieve a very good reconstruction of the nose. You can have a very large defect like that, where you actually get a complete, removal of the the middle floor is gone. I would use a combination of titanium mesh and a little bit of Allylectomy bone graft just for the interior part of the floor, and then pop a anterolateral thigh flap to and we're talking about a fibula or subcutaneous flap. You can say that the infrastructure maxillectomy because of involvement, and you could actually use a fibula flap here, which can be basically placed inside. And as we were discussing before, in this particular patient, the bone part of the fibula flap is offset. It's actually much higher. And that's the reason why once everything is shrunken in place, you can see a really nice flat palate here. So the prosthodontist and the dental friends can actually do a great job on something like this. This girl eventually had some dental implants in the fibula. I haven't got the pictures right now, but she had a very good result. This is a case of total involvement. This is from one of the chapters I wrote in the book on fungal infections. It's basically where you can see there's avascular necrosis. The disease has totally been treated, but when you actually go inside, you actually find something like this. And once you actually remove all the bone, there's a huge defect of the palate, the entire antrum and the orbit. We've actually used a large anterolateral thigh flap with 2 pedals, one in the palate and one here in the orbit. Obviously, whenever he speaks, this moves, but overall, this patient's been able to get to a good amount of liquid diet. The patient can actually speak legibly as well because part of the soft palate was left behind. And I've been following him up for almost 7 years, and he's doing quite well. This chap essentially, again, you can see a complete, this chap came from Nigeria, entire thing eaten away. When we opened up, most of this bone that you see, the part of the maxilla and the mandible had to be taken out. We again used a double pedal anterolateral thigh flap, microvascular flap, which was plugged into the neck here. You can see the outer island here and the inner island here. And we'd not tasted any tea for a very long time. So he still has a Ray's tube here, but then we've started orally in this picture, and as you can see, extremely happy man there. So I think as we were all kind of discussing, it's a multidisciplinary approach, and we all have to work in tandem with each other. If you don't do that, and this is something that can happen, we're working from both sides, and we may not meet together. So thank you very much. I think Sumit, you organized an extremely good panel discussion on this. I really thoroughly enjoyed. I learned a lot as well. And this is our team at Max, my team at Max Hospital Satya. Thank you. I think it's good time.
Dr. Vijay, we can take questions. Dr. Chaudhary, you can just stop the screen sharing, and thank you. Yes, thank you so much for such wonderful cases. And quickly, we can have a few questions. Dr. Vijay? Yeah, just unmute yourself, Dr. Vijay. Yeah.
Can you hear?
Yes, yes.
There are many questions, but many has been answered during the panel. I think almost you have covered everything. And there are a few questions like Dr. S.K. Kakar from Delhi. He has asked, we had a patient with only involvement of anterior part of left sphenoid after COVID. Should we explore it?
I think, Dr. Manish, you had shared a case, so maybe you can just put us light on this, that isolated sphenoid involvement with mucor, and just be, what should be done?
Yeah, it looks rosy to evacuate because sphenoid is a closed sinus, but a very can be a trap because sphenoid also means borders, and sphenoid means lateral pterygoid recess. It means disease going into the clivus, into the basisphenoid. Of course, one of the cases that you mentioned and Dr. Neelam mentioned, ICA involvement, thrombosis. We had, I know we couldn't share that case which I had sent, the guy with the ICA thrombosis and through infarcts into the brain every now and then. It's a very difficult area to treat. But yes, if it's an isolated sphenoid involvement, a very aggressive debridement initially, with the careful inspection of all bony margins. I made that mistake, or should I say, I've seen that happen. Sphenoid mucosal disease behaves differently, but if you see necrotic bony margins of the sphenoid also involved, it means a much more aggressive disease and has to be dealt like a death trap for the patient. It's a very difficult situation. It will progress even if it has not, and one must be very careful of this disease. It will almost invariably go ahead.
Right.
We have to explore, right?
Yes.
Yeah.
And the most important question in everyone's mind is when we are going to stop the medication and when we are going to declare the patient, you are mucor free, you are fine, you can go ahead. When we are going to show the green flag, green signal.
Dr. Neelam, we want your comments, please. Last 5 minutes, I know. But we have finished on time. It's just 8:05. Dr. Vijay, aren't we on time?
Yeah.
You can't expect me, I have finished on time. I can see Dr. Vaid cooking in the kitchen.
Unmute.
Can't hear you.
Sumit, before anybody does, I'll take this opportunity. You've done a fantastic job, and kudos to you.
Super.
Yeah.
Thank you.
Just to say, Dr. Sanjay Vaid is washing utensils, I'm cooking. Okay, let's get that straight.
I wanted to hear that actually. Hello, sir. We can see you in the background.
Okay, so just to answer that question, it's a very tough one, Vijay. And like I said before, in all our patients, we've just managed to stop the medication on only 2 of them. So I think it's going to be a combination of how the patient is doing clinically that you're going to really decide when to stop. But on an average, we are giving at least posconazole to our patients for, we are telling them you're going to have to eat it for at least 3 months. That's what we're telling them when we start off. So you're looking at amphotericin, then they go on to a switch over onto posconazole, and you're looking at posconazole for 3 months.
Great.
Is there any investigations further to be done at the end of completing the course of medicine, like a blood test or any radiological investigation, or just an endoscopy? Will say?
No, it's just endoscopy, how they're doing clinically, that's all. That we will take a call. But what we are telling them is 3 months.
After that also they have to be under follow-up for
yes, they are all told that they have to be with us for at least 6 months to 1 year. But look, we are all in a very early stage. None of us knew that, like we are having a second panel so soon. We didn't know that, we are going to be facing these sort of issues later on. So I think we are still learning. This disease, right from when it's hit us, has been just teaching us newer things. So it's too early.
That tells us that we will be having one more panel after a few months.
Right.
Thank you so much. With that, I would like to conclude this session. I would like to thank Dr. Sumit for the wonderful moderation on this hot topic.
Thank you.
There's so many interesting and difficult cases, and I'm sure everyone will.
Sumit, fantastic.
And everyone will agree that you have covered almost all aspects of the problem what we all are facing in managing these patients. The importance of follow-up and the rehabilitation has been well explained and discussed in this panel.
Trust me.
Also, I would like to place my sincere thanks to all the panelists who have shared their experience and knowledge on this particular topic with few controversies as usual, which always expected, and was a healthy debate. Thank you all once again. And I would like to thank GSK and their team members who are always there with IAOHNS in supporting these kind of academic meetings. Thank you one and all. Thank you.
Thank you very much. I was quite nervous to have such a big galaxy of stars with Mohan sir watching, and Dr. Neelam, she's always.
Sumit, इससे ज़्यादा compliment नहीं मिलेगा, हाँ बस.
Thank you so much. Thank you.
We are still live. I'm just stopping the live stream.
Man, stopped my